So today we will discuss about the leukoplakia. Right. It is very important lesion. Commonly you'll be asked question about leukoplakia. So what is leukoplakia? It is defined as a white patch or a plaque that cannot be scraped off. This is the difference between oral leukoplakia and candida, right? And also characterized clinically or pathologically as any other disease, because in case of candida, when you'll scrape, it will scrape off, but you cannot be able to scrape leukoplakia. So it is generally referred to as the firmly attached white patch, firmly attached on a mucous membrane, which is associated with an increase in risk of cancer. That's why it is called pre-malignant lesion. The edges of lesions are typically abrupt and the lesion changes with time. Now, advanced form may develop into red patches. Generally, it is white patch, but in case of advanced lesion, it can become to red patch. There are generally no other symptoms. It is usually occur within the month, although sometimes mucosa in other parts of gastrointestinal tract, urinary tract, or genitals may be affected. Right. Mild leukoplakia is generally harmless and often goes away on its own. More serious can be maybe linked to oral cancer. These must be treated promptly. Now onwards, I'll show you the pictures, how it looks like, and what are the types and what are the features and how to prevent from the leukoplakia. So you can see over here, it is a white patch on the side of over the side of the tongue, and it is cheek. It generally starts from this corner of the mouth and follow the line of your occlusion, right? Occlusion, where occlusion will occur, it follow the line. Generally, you can see. Now, according to statistical data, it affects 1.5 to 12% of total population, right? And usually affects age of 40 year, right? And prevalence increases rapidly with age, particularly in males. So just remember these things. Over the age of 40 years, average age is 60 years, and generally affect males than females. And 8% of the males over the age of 70 years are reported affected. But if you will get question, just mark 60 years, because the average age is 60 years and more of in the males, right? And 17 to 25% carcinoma in situ, and 5.4% may develop SCC in smokers. It rises to 16%, right? So definitely smokers and alcoholic people are more prone to leukoplakia, right? Now, generally you will get question. So basically leukoplakia is the most common precancerous lesion, right? It is most common precancerous lesion. So that's why you'll get question from this: most common precancerous lesion, right? And erythroplakia is considered most malignant precancerous lesion. This is most common precancerous lesion, and the most common malignant precancerous lesion is erythroplakia. This was the question. This was the question asked in previous examinations. So let me tell you. In Karnataka 99, what is the most common precancerous lesion of oral malignancy? The answer is B, leukoplakia. Most common precancerous lesion. And if the question is most common malignant precancerous lesion for oral malignancy is erythroplakia, right? Now the basic etiology, as I have already told you, alcohol and tobacco. The people, those who are consuming alcohol and tobacco, are more prone than normal. Mechanical Etiology may be sharp tooth or crown margins, irritating denture clasps. So you can see if the tooth is sharp, which is regularly irritating the mucosa, and you're irritating denture clasps. The RPDs which are having clasps, they may irritate mucosa regularly. They may develop leukoplakia. Pre-malignant epithelial changes, Candida albicans, ultraviolet radiations, and so ultraviolet radiations, they may be the cause, and trauma, toothpaste or mouth rinses, right? Now the main sites of predilection are lateral and ventral tongue. Lateral, as I have already shown you the picture, lateral side of the tongue, like right, then floor of the mouth, alveolar ridge mucosa, corner of the mouth, less frequently the soft palate and lip, right? Less frequently the soft palate and lip. So basically, it starts from commissures, then your corner of the mouth, then your lips, then your tongue, then your palate, then your alveolar ridges, then your lower, then at last your soft palate and gingiva, right? This is the sequence, right? So you can see it like that only. This you can study or remember by yourself, otherwise it is very difficult to remember, and it is actually not very much important. Now there are various clinical forms: homogeneous leukoplakia, non-homogeneous leukoplakia, proliferative verrucous leukoplakia, erythroplakia, which we will study separately, sublingual keratosis, oral hairy leukoplakia, and syphilitic leukoplakia. We'll discuss them one by one. Now come to homogeneous leukoplakia. In case of homogeneous leukoplakia, you can see the uniform flat appearance, uniform flat appearance that may exhibit shallow cracks and has a smooth plaque-like wrinkled or corrugated surface throughout with a consistent texture throughout. You can see here the corrugated surface throughout. The corrugated surface is present throughout, right? I'll try to show you the corrugated surface. This is the corrugated surface throughout, so it is uniformly present, right? In case of homogeneous leukoplakia, this is present basically in the floor of the mouth. In the picture you can see in the smokers, right? So, and the biopsy showed, if you can see over here, it is in the floor of the mouth, and the biopsy which has done showed hyperkeratosis. Hyperkeratosis is shown in the homogeneous leukoplakia, right? So homogeneous leukoplakia appears as a translucent white raised area, and it is a non-palpable, that is same as surrounding mucous membrane. And differential diagnosis for the homogeneous leukoplakia is hyperplastic lichen planus. Just remember that also. DD is hyperplastic lichen planus, right? Then come to non-homogeneous one. This is the picture of non-homogeneous one. In the non-homogeneous leukoplakia, it appears non-uniform. Non-uniform, you can see somewhere it is red, somewhere it is white. The color may be predominantly white or a mixed white and red, right? White and red. And the texture is again is irregular compared to homogeneous leukoplakia. You have seen there is irregular, but it is throughout. But in this case, non-homogeneous one, well, that's why it is non-homogeneous, irregular compared to homogeneous leukoplakia, and maybe flat, papular, nodular, or exophytic. Flat, papular, and nodular or exophytic, right? So this is on the buccal mucosa in the picture, and it is basically non-homogeneous one. Why it is non-homogeneous? Non-homogeneous one is basically it is non-homogeneous in texture, right? Then come to your proliferative virucious leukoplakia. So PVL, proliferative virucious leukoplakia, it is a high risk subtype, high risk of non-homogeneous leukoplakia, and it is uncommon, usually involves the buccal mucosa and the gingiva, right? And it is characterized by extensive papillary or viroid keratotic plaque that tends to slowly enlarge, right? You can see here, slowly enlarge. It looks actually very, very dangerous, and it is actually very, very dangerous, and to tend to extend towards adjacent mucosal site, right? And initially it may be flat. Right now it is very much prominent and exophytic. So proliferative virucious leukoplakia first described by, it was first described by Hansen and is associated with high risk of progression to SCC, right? And it may be associated with the human papilloma virus, right? And seen as white papilliferous or cauliflower-like growth. Cauliflower-like growth, you can see here. Commonly seen in the region where the quid is kept for the long time. Quid for long time, right? And differential diagnosis again is the verrucous carcinoma. Just remember the DD is verrucous carcinoma, right? Next comes, I'm trying to explain important things only. So you have to remember these things by heart, right? The next one is erythroplakia. I'll give you very good idea about leukoplakia in the next video, right? So we'll not do it here. Then sublingual keratosis. Sometimes this term is used to describe leukoplakia for the floor of the mouth, right? Or under the tongue. Floor of the mouth or under the tongue, right? Basically, it is a different clinical entity for idiopathic leukoplakia, right? And you can differentiate this type of leukoplakia by the location only. As I have already told you, it may be present under the tongue and floor of the mouth, right? So this sublingual, that's why it is sublingual keratosis, and it is bilateral and possesses a parallel corrugated wrinkled surface texture described as ebbing tight, right? Ebbing tight. Just remember this. It is not very much important, but just remember this. And in basically oral leukoplakia may be found in all sides of oral cavity, right? So this may be differentiated. This is differentiated according to the site, and non-smokers have a high percentage of leukoplakia at the border of the tongue compared to the smokers. And for the smokers, the floor of the mouth and lateral baldness of the tongue are high risk site for malignant transformation. Basically, the high risk is from the floor of the mouth and little baldness of the tongue, right? Then come to the next one is oral hairy leukoplakia. So hairy leukoplakia is the second most HIV associated oral mucous lesion after candidiasis. This is second most common lesion associated with HIV, right? And it is non-malignant, non-pathognomic for HIV since other immunodeficiencies such as cancer, chemotherapy associated with the hairy leukoplakia. And it is commonly seen in the lateral borders of the tongue in the form of vertical white folds, right? And it is a corrugated hairy white lesion on the side of the tongue caused by opportunistic infection with Epstein-Barr virus on a systemic background of immunodeficiency. Always HIV infection, almost, right? Then your syphilitic leukoplakia, again not very important. And or in case of oral hairy leukoplakia, there was a question which was asked somewhere in KCET 09. Presence of Epstein-Barr virus in hairy leukoplakia can be demonstrated using following methods, except Zank smear, polymerase chain reaction, in situ hybridization, or electron microscopy. The answer is Zank smear, right? Zank smear. Just remember this. Right? EZANCK, smear. Syphilitic leukoplakia is a white lesion associated with the syphilis, especially in the tertiary stage of infection, and not considered to be a type of idiopathic one, since the causative agent is Treponema pallidum in third stage of syphilis. And it is now rare, but when syphilis was more common, this white patch usually appears on the top surface of the tongue and carried at a high risk of malignant transformation. Now, I'll give you a brief idea about the mucosal changes, right? So, in case of normal mucosa, you can see normal epithelium, dysplastic epithelial cells, lymphocytes, candide hyphae, and keratin layers. right? Now, in case of thin, smooth leukoplakia, you'll be able to see hyperkeratosis, acanthosis, lymphocyte occasional. Just remember this: acanthosis is present, okay? And in case of thick fissured leukoplakia, just don't remember this. Remember this: granular viscous leukoplakia, irregular hyperkeratosis, ratapex you can see, lymphocyte, moderate to severe dysplasia. Dysplasia and acanthosis is very common in case of leukoplakia when evaluated histopathologically, right? And in erythroplakia, which I'll give you idea in the next video, irregular hyperkeratosis and epithelial atrophy and severe dysplasia, right? Now, what is the clinical significance? It is basically a unusual one, unusual white patch inside the mouth which cannot be scraped off, right? And patient will complain most of the time sensitivity to heat, spicy food like chilies or masalas in Indian food, sensitivity to touch and other irritations. These patches can vary in appearance, may have following features: white or gray color, thick hard raised surface, hairy leukoplakia only, red spot, rare, right? And as I have already told you, acanthosis is very much common, which is epithelial thickness, and dysplasia is most common, right? And the ratepeg, you can see the drop shape, wider at the base, then more superficial. Diagnosis is basically physical examination, the history of the patient, right? And biopsy you can take. The microscopic examination shows keratinocytes scraped from a buccal mucosa, right? So usually indicated to rule out other causes of white patches. Also, to enable the detailed histologic examination, you can see the presence of any epithelial dysplasia, as I have told you, the acanthosis, right? The treatment part is most common. Most patches improve on their own and don't require any treatment, right? Basically, ask the patient to leave spicy food and basically trigger factors: tobacco, alcohol, and your spicy food, right? If there is a dental problem, just evaluate that and correct it, right? And if the biopsy comes back positive for oral cancer, the patch must be removed immediately to prevent the spread of cancer. Small patches can be removed by more extensive biopsy using laser therapy or scalpel. Large leukoplakia patches require oral surgery. Hairy leukoplakia may not require removal. The dentist and doctor might prescribe antiviral medication to help stop the patches from growing. Epstein-Barr virus, just remember that. Topical ointment contain retinoic acid, can also be used to reduce patch size. Right. Now, one very important thing is the modified classification of oral leukoplakia. Modified classification. Depending upon the size, L1, L2, L3, Lx. In case of L1, the size of leukoplakia less than 2 cm. In case of L2, size varies from 2 to 4 cm. And in case of L3, more than 4 cm. This is 2. And in case of Lx, size not specified. Then come to the clinical condition, the clinical condition is C1, C2, Cx. It is homogeneous, it is non-homogeneous and non-specified, right? Pathologically, P1, no dysplasia, P2, mild dysplasia, P3, moderate, and P4, severe, right? Then depending upon the area, S1, all areas except floor, S2, floor, and except floor and tongue also, floor and tonsil, SX not specified, and stages are 1, 2, 3, 4. So in case of stage 1, L1, S1, C1, P1 or P2. That means it is in case of stage 1 if the lesion is less than 2 centimeter and all areas except floor and tongue, homogeneous in clinical condition, and maybe mild dysplasia or no dysplasia. Like that, the stage 2 is L1 or L2, S1 or 2, P1 or 2, and C2. L1, L2, S2, C2, P1 or P2. Any of L, S1 or C, L1, S1 or C, P3 and P4. That means in fourth stage, it is moderate to severe. So fourth stage is advanced stage, right? So that's all about leukoplakia. Thank you so much.